In medicine, we have a word for the gap between a recommended treatment and the treatment a patient actually receives. We call it a delay. But delay is a clean word for something that is not clean. Delay means a scan that was ordered in October and approved in January. Delay means a surgery scheduled for the fall that does not happen until spring. Delay means a cancer that had time to grow while a form sat on a desk. Prior authorization. The words sound procedural, administrative, neutral. They are none of these things. This is Case File 007, The Denial Machine. Chapter. What prior authorization actually is. Prior authorization is a requirement imposed by health insurance companies that physicians obtain approval before providing certain medical services to their patients. In theory, it exists to prevent unnecessary care. In practice, it functions as a gatekeeper between a physician's clinical judgment and the patient sitting in front of them. The process begins when a physician determines that a patient needs a specific treatment, an MRI, a medication, a referral to a specialist, a surgery. The physician submits a request to the insurance company. The insurance company reviews the request against its internal criteria. Then it approves the request, or it denies it. The reviewing entity at the insurance company is not always a physician. It is sometimes a nurse, sometimes an algorithm, sometimes both. The reviewer has typically never examined the patient. They have not spoken with the patient. They are working from a summary of a medical record, evaluated against criteria that may or may not reflect current clinical standards. The physician who ordered the treatment has often spent years training in that specialty. The reviewer who overturns their decision may have spent minutes on the file. This is the architecture of the modern prior authorization system. Chapter. The paper trail of a denial. When a prior authorization request is denied, a letter is generated. The letter cites a reason. The language is standardized. Clinical necessity not established. Conservative treatment not yet exhausted. Service not covered under current plan benefits. Does not meet inter-qual criteria. Experimental or investigational. These phrases appear across millions of denial letters each year. They are clinical sounding. They are designed to sound final. They are not final. Physicians and patients have the right to appeal, and the appeal process, when pursued completely, reverses denials at significant rates. Studies examining external independent review outcomes have found overturn rates exceeding 50% in some states. The system counts on exhaustion. It counts on the physician not having time to write the appeal letter. It counts on the patient not knowing they have the right to request a peer-to-peer review. It counts on the process feeling too complicated to complete. The paper trail of a denial is long by design. Chapter. The Human Cost. The American Medical Association conducts an annual survey of prior authorization practices. The findings are consistent across years. In their most recent survey, 93% of physicians reported care delays associated with prior authorization requirements. 24% reported that prior authorization had led to a serious adverse event for a patient in their care. 1 in 4 physicians. The cases that reach public record tell specific stories. A patient with stage 3 colon cancer whose chemotherapy regimen required prior authorization. The authorization was denied on initial submission. The appeal process took 3 weeks. The patient's oncologist documented that the delay allowed measurable disease progression. A child with severe autism spectrum disorder whose applied behavior analysis therapy was denied as not medically necessary. The family spent 4 months in the appeals process. During those 4 months, the child's behavioral symptoms escalated significantly, requiring an emergency psychiatric evaluation that the insurance company then also required prior authorization to treat. A patient with a documented ACL tear confirmed on MRI, whose surgery authorization was denied pending additional conservative treatment. The required conservative treatment period was 6 weeks. At week 4, the patient fell and sustained a complete meniscal tear in the same knee. The subsequent surgery was more complex, more expensive, and had a longer recovery than the original procedure would have required. These are not anecdotes. They are documented patterns. Chapter: How the system is designed to exhaust you. Health insurance companies spend billions of dollars annually on prior authorization infrastructure. This is not philanthropy. It is investment with an expected return. The return is a percentage of claims that are submitted and never collected. Physicians and patients who begin the appeal process and stop before completion. Treatments that are delayed long enough that the clinical window closes. Patients who switch to a less effective but more easily approved treatment because the fight is not sustainable. There is a specific term in health insurance economics for revenue generated through denied claims that are never appealed. It does not have a flattering name in clinical circles. The process has specific friction points that function as attrition mechanisms. The initial denial letter arrives with a deadline for appeal. Miss the deadline, and the right to appeal may be forfeited. The peer-to-peer review must be scheduled within a specific window. The external independent review request requires documentation assembled from multiple sources. Each step requires time that a practicing physician managing a full patient panel does not easily have. This is the design. Chapter: What physicians are doing about it. Resistance to the prior authorization system has taken several forms. Legislatively, the Improving Seniors Timely Access to Care Act passed the House of Representatives with bipartisan support. Multiple states have enacted step therapy reform laws, restricting insurers' ability to require patients to fail cheaper treatments before approving the one their physician recommends. The Centers for Medicare and Medicaid Services has issued new rules requiring Medicare Advantage plans to streamline prior authorization processes and increase approval transparency. Clinically, physicians have begun treating the appeals process as a skill set rather than an administrative burden. The physicians who win the most appeals are not necessarily those with the most time. They are those who know the language, who cite the right guidelines by name, who invoke the correct regulations in their letters, who arrive at peer-to-peer calls with structured talking points and anticipated objections already prepared. The evidence on this is consistent. Documented clinical necessity, specific guideline citations, and escalation through the correct channels reverse a significant percentage of denials that would otherwise stand. The appeals process is learnable. The language is systematic. The hierarchy of escalation, from first-level appeal to external review to state insurance commissioner complaint to congressional inquiry, follows a documented path. Physicians who know that path win more than those who do not. Chapter: Closing statement: Prior authorization will not disappear from the American healthcare system in the near term. The economic incentives that sustain it are significant, and the legislative momentum, while real, moves slowly. What can change is the individual outcome. The physician who knows how to write an appeal letter that cites inter-qual criteria challenges directly. The patient who knows they can request a peer-to-peer review, file a state grievance, and escalate to their congressional representative's constituent services office if necessary. The system is designed to exhaust. The answer to exhaustion is efficiency. Knowing exactly what to say, where to send it, and what comes next if it is denied again. That knowledge exists. It is learnable. And the physicians using it are winning cases the system expected them to lose. This has been Case File 007. The denial machine, the Postmortem Files. The file remains open. If you are a physician spending hours on prior authorization appeals that should take minutes, the link in the description is worth 30 seconds of your time. Clinical Draft has built AI prompt packs specifically for physician documentation. The Prior Auth Appeal Letter Pack contains 30 plug-and-play prompts covering every stage of the denial and appeal process: first-level appeals, urgent appeals, peer-to-peer talking points, escalation letters, patient-facing scripts. $37. One time, the link is in the description.